Well, welcome everyone. Welcome to this virtual online event hosted by the ABS. We're really excited to be here today. We're excited for all the attendees that have signed up. We want to bring you this online content, make it meaningful to your practice. I want to thank Melissa Pomeroy for putting this together and promoting this. My name is Pete Rossi. I'm going to give it a couple of seconds here before I introduce the panel. But again, thank you for being here. I have a few announcements to get through, so I might as well begin on that. I just want to remind everybody that there is a call for abstracts for the annual ABS meeting, which will be at the end of June. We have extended the deadline. The new deadline is February 28th, 2021. So bring your abstracts. We're looking forward to reviewing them. Secondly, we are accepting applications starting now for the 2021 class of fellows of the ABS. The criteria is a minimum of 15 years of it's 15 years of membership with the ABS, and then there's some sub-criteria, but consider putting your application in, application of a colleague that has been a part of ABS for 15 plus years. Wonderful to have more FABs. Another reminder, we are in our membership drive. Generally, the membership drive expires December 31st, but of course, there's a grace period. It's been a strange year for all of us. We are trying to be resilient through all this. We are trying to create virtual online events as meaningful content for your practice. We're working really hard at that. We have a number of online activities that are going to roll out along the lines of workshops, academics, cooperation with grand rounds of urology. So stay tuned. We're going to ensure that you can get as many SAMs and CMEs as you need. SAMs in particular, you're going to be able to get, just in what I have planned right now, or we have planned right now, 12 to 15 over the next several months, so you can keep up to date with all your accreditation. In 2021, we plan to further enhance our programs and provide these tools to you. And again, we want to hear from you. We want to hear from what you want to talk about and hear about. So thank you very much. So another announcement, we have our next webinar on February 4th at 4 p.m. This is Eastern time. It is titled The Medical Physics Nuts and Bolts of MRI for GYN and Prostate Care. It is February 4th, and me personally, I'm not going to be available. I'll be out of clinic, but I know that it will be on the ABS YouTube account just a few days later, so I'll be able to review with my team. The leadership behind this is Dr. Jabira Kohan and Firas Mortada. Firas is our current president, and they're going to discuss the benefits of MRI for HDR brachytherapy, make you aware of the published resources that are available and coming, and understand practical considerations as they arise when you take your practice from MRI into an MRI world of integrating it into HDR gynecologic and prostate brachytherapy programs. Our next announcement is today is a CME course, a SAM, and there will be a link to the test that will be sent towards the end of the webinar in the chat forum. So please look out for that. It's a 5-question test. It will take you just a matter of a few minutes and satisfy a key SAM for the year. And then now, finally, before I introduce our panelists today, I want to let you know that we're actively monitoring the chat forum. Melissa and I, Albert and Matt, that we want this to be interactive. We do not plan this to be an hour of didactics. We want this to be the content we give you, but a lot of time will be at the end, especially for Q&A. But during it, I'll be monitoring it and trying to address questions that arise as Albert and Matt lead us through the discussion. So with that, we have a lot of participants. It's 3:05, and I'm gonna change my screen here to start the presentation. And here we are. I'm lucky to be joined by Dr. Albert Chang today. Albert's radiation oncologist, associate professor at UCLA. He's also the director of brachytherapy services, and he's the vice chair of their operative services at UCLA. Very fortunate to have him. Albert is an active prostate brachytherapist. He uses the technique we're using today. A part of the point here was to bring together 3 different practices that do a variation on the same theme. And Albert is really key to this. He does more than 40 of these a month. If you can imagine the amount of time he spends in the OR and actively participating in his own brachytherapy program. I have Matt Giles with me. Matt is the lead physicist at Emory and a key member of brachytherapy there. And I've worked many years with Matt previously. Matt does over 30 of these cases monthly and has for most of a decade. And then myself, this is also my technique as well, CT and now CT MR based HDR prostate brachytherapy. And what we're going to do today is talk about the implant itself, some tips and tricks and pitfalls that we've learned along the way. And we're going to go over contouring, but a real key to what we're doing today is Matt's going to bring us through the real-time treatment planning so you can see what we can do along that way. Excuse me for a second, just want to make sure I'm monitoring the chat. Okay, so disclosure, just to get this out of the way, we are talking about multiple technologies today. They are all FDA approved. We have no conflict of interest, but for instance, we'll be talking about CT and MRI imaging from GE, MIM software, on central treatment planning software, Orion MRI markers, gold markers by Theragenics, the Schlesinger immobilization board, among other things. So we are not, as ABS, trying to be brand specific in any way, but this is just what the 3 of us practice on a daily basis. Again, the learning objectives, which I've reviewed real quickly, but what we're trying to do here is represent our ABS workshops that we have held over the years. Our last one was in Denver prior to the pandemic, 2019, where we did this workshop live and we went over treatment planning solutions for ultrasound-based and CT-based, CT MRI-based, with both HDR and LDR. The last one we hosted was over 100 members in attendance, 30 plus teams of urologists, radiation oncologists, and physicists. Another key point of this is we're sticking to our own guidelines, our ABS guidelines, the ACR appropriate criteria, and that's really a reference for you. We have additional handouts that go along with this. Specifically, we're talking about CT-based planning today with the integration of MRI. And again, I just want to let you know that this is supposed to be interactive. Let us know on the chat line. I'm firing it up right now. And that this will be on our ABS YouTube feed in a day or 2. So to start with, I want to ask Dr. Chan just to bring us through the data as we begin our conversation today.
Thanks, Pete. Glad to join all of you in this presentation. Hopefully, you'll learn a lot as well as I from this meeting. So this one slide, it's a review that one of our residents here at UCLA compiled, looking at monotherapy and its biochemical control. Here you can see in multiple studies for low to intermediate risk disease, the results are really great with brachytherapy as monotherapy. Here you can see biochemical relapse-free survival in the 90% range, for low to intermediate disease, with many of the studies up to 5 years of follow-up. And then one study with Dr. Damanis here at UCLA has follow-up up to 10 years. These studies were mostly done with multiple fractions. When we tried to go down to one fraction as a group, the results were not as optimal, with a drop in the biochemical relapse-free survival. So right now we're recommending for monotherapy to do a multi-fraction, at least 2-fraction regimen, and we'll get into that later. Next slide. So in patients with more aggressive disease, we tend to use brachytherapy as a boost in addition to external beam treatment. Here's a phase 3 study by Peter Hoskin out of the UK, and it's a phase 3 study that compared the addition of HDR brachytherapy to external beam versus external beam alone. And you can see that the relapse-free survival is improved by approximately 20%, very similar to that seen with Ascend RT with the improvement with permanent seeds. And of note, the toxicity was not increased with the addition of high dose rate brachytherapy. Many of these patients had intermediate to high risk disease, and about 75% of the patients had hormone therapy. Next slide. And the results were duplicated in a cooperative group setting. This was a study led by Joe Shu at UCSF, where he looked at HDR combo with external beam using CT-based planning, what we're going to talk about later. Median follow-up of 10 years. Here you can see that the patients did really well overall. Not shown is that the biochemical relapse-free survival was 14% at 5 years and 22% at 10 years, which is actually pretty excellent for more aggressive disease. Grade 3 or greater toxicity was still very low, less than 5%. So there's been a lot of criticism about adding brachy as a boost and having an increased toxicity. This was not seen in the prior 2 studies that I just mentioned. Local control is excellent, 98% at 10 years. Next slide.
Yeah, and here we are. And so I'm going to break you through the computer, but a couple key points that Dr. Chang brought out is the local control there was 98%. You know, dispelling the myth that, you know, if you do surgery, you always have radiation. If you do radiation, you don't have necessarily a good backup plan, but it's really an uncommon scenario. Don't you think, Dr. Chang?
Agree. You know, I think I always tell patients, you know, you should pick the modality that you feel most comfortable with. You shouldn't. I think a lot of surgeons, like what you said, mentioned, oh, if you get radiation and you fail, you can't get surgery. But you know, the incidence of local failures, as you can see, is really low. You know, patients don't fail locally. If they fail in the nodes or distantly in the bones and such.
Yeah, that's right. You know, with a PSA controlled at 85 to 88% going out past 9 years, depending on how you define that, and with a PSA control rate less than 50% on the external beam alone arm here, you know, Juanita Crook always talks to me, and Amir Keys, about, well, if you're going for cure, you know, isn't this what you should be looking for? And that's always stuck with me as this data, this controlled level 1 evidence that's come out showing this benefit to brachytherapy boost. So let me get into the implant. And I talk about this when I talk about groups about the implant, the creating a high reliability program. And high reliability is a buzzword in healthcare administration right now. A high reliability organization is an organization that succeeds in avoiding catastrophe in an environment where normal accidents can be expected due to risk and complexity like brachytherapy. And we talk about the path to high reliability is shown by this virtuous cycle where you have engagement and safety leading to quality, experience, and efficacy, or efficiency, excuse me. And I truly believe that if you have structured your methods for a high reliability program, that you will ensure long-term quality in your program. We are talking about HDR today. We are specifically talking about CT rather than ultrasound-based HDR. I'm a brachytherapist that does both, and I really see that they are more similar than they are different in so many ways. But why I like brachytherapy for men with prostate cancer is for a lot of reasons. I like what the dose can do, the cure rate. I like the logistics. When I began, it was 44, 45 sessions of radiotherapy versus 1 or 2 for a lot of men with intermediate risk prostate cancer. There's cost effectiveness and less financial harm to these gentlemen because of that. And you're also limiting the amount of external beam radiotherapy to younger men. And it's tellurized real-time treatment in both LDR and HDR. With HDR, I always feel like it's just a little, it has this elegance to it of flexible treatment planning. It's very tech forward, so urologists really dig it for that matter. It is targeted and personalized. It does minimize radiation exposure to the men. And when you have a needle in place, there's this maximal forgiveness I always find. I am happy with the acute and late side effect profiles. And I really believe men and urologists like it. It's something that's been constantly reinforced in my career. And just to see Dr. Chang's thoughts on these matters or Matt's as well.
Yeah, I can agree more with you in terms of why I like HDR. I feel, in the era of personalized medicine, this is probably the most personalized way or tailored way to deliver radiation to the prostate. You put radiation directly where you need it, you can tune it, and there's less integral dose to the surrounding normal tissues. We always talked about minimizing dose, ALARA. This is minimizing dose even more so than other modalities, even protons. I think it's very forgiving in terms of how you can tune the dose. There's along the way, we can get into that later, but there's various steps where you can make adjustments. And in terms of brachytherapy, there's been a lot of myths that brachytherapy has high toxicity. I think you saw from the prior studies that we just reviewed, and in our experience, we don't see this high toxicity rate. 30% toxicity that people see. So that's what patients do really well. And in terms of dose escalation, there's been a lot of data that going to higher doses increases your relapse-free survival. HDR allows you to deliver even higher doses than external beam to your target. So that's why I like HDR.
Yeah. So just to talk about, again, there's 3 different ways to do HDR. There's ultrasound based. And what we're talking about today is the CT based, and then the CT integrated with the MR. From our ABS guidelines, ACR appropriate criteria, these are what I do, and I believe Albert and Matt practice the same form of fractionation. These are evidence-based, and these are probably the most common in our community right now. However, salvage can be given a number of ways that I'm very supportive of.
Yeah, those are very similar fractionations to what we use. Yeah, awesome. I was just looking at the chat box. I don't know if we should start going through that now or later.
Yeah. So without a doubt, we're going to get to this. Scott, thank you for the question. It's about simulation. And I think this is a really important one, and we'll yeah, absolutely. We have a couple of tips along those lines. I think, and just very quickly, yeah, it's always a challenge to get the dose at the bladder base, and diluted contrast. Just you can talk about a 5% or half cc solution. Usually goes a long way to light up the bladder if you're doing CT alone. Mm-hmm. And then you have a couple of chances at CT simulation to advance your needles if you're not particularly happy at that time.
Yeah, let's do that. Like, we'll get to this question. Yeah.
Okay. So there are contraindications, and I'm not going to dwell on this. We all know them. ATs and rectal fissulas are uncommon, but I want you got to think like a surgeon when you do brachytherapy. You got to look for unacceptable operative anesthesia risk. I've had tons of guys that I thought would be brachytherapy candidates because of back issues, fusions and such, hips are frozen. They're not appropriate for the position. So think like a surgeon. I'll let you go through this, Albert. There's always relative contraindications, and this is the list we've written about, but I don't really live by this list whatsoever. And why don't you take us through it a little bit?
Yeah, I think these are recommendations from the ACR ABS in terms of relative contraindications like ECE, SVI, large size, greater than 60 cc's, or patients with a lot of urinary symptoms. I think some of the solutions that you can see is to use MRI guided. We use MRI fusion at times to help us to guide it. I think in terms of ECE and SVI, I think maybe potentially for permanent Cs, but I think with high dose rate brachytherapy, you can directly implant that area of the ECE. You can directly implant the seminal vesicles and load a ton of dose, and even spare the surrounding normal tissues. So I think you could get around the ECE and SVI. The arch, I think you can hyperflex the hips. You can drop the probe as it says. What we do is we do a freehand technique. So we're not as dependent on using a template that's fixed to the ultrasound. We can come in at different angles to get around the arch. So large prostates, arch interference is not as much of an issue. But I think hyperflexing, like the legs being posterior toward the patient's head will often lift the pubic arch. Prior TURP, we published a paper on prior TURP that shows that it's feasible with low toxicity. One of the things you can do is instill 10% saline with contrast through the Foley catheter. And then you can push the balloon up so that the contrast can seep into the TURP defect. Also, another way is we've developed, there's a publication with Dr. Shu from UCSF. I was on that publication, but where we took a triple lumen Foley catheter and we made a modification. If you want to look it up, we cut out a port, on the side of the third lumen, and then we can instill contrast and fill up the TURP so we know where to avoid. And large median lobes, sometimes you can ask the urologist to do a TURP before. I always recommend a TURP before, and it doesn't have to be a huge TURP. It could be a channel TURP. And then you want to do this before instead of after your procedure to minimize the risk of complications, to minimize incontinence. I think prior radiation therapy, prior pelvic surgery, IBD, I think these are good cases for HDR because you're able to spare, the surrounding tissue from excessive doses of radiation. Prior radiotherapy will make it even more difficult for the surgeons to go in because oftentimes the fat planes, their dissection planes are obliterated in that sense, or even with IBD. So, yeah.
Yeah, absolutely. Kind of opportunities, not necessarily contraindications, in my opinion. And there's data to support moving forward, and if that's the patient's choice, with informed consent in each of these scenarios. So I want to talk about the workflow for CT and MR-based HDR just real quickly. It is a different process than ultrasound-based, which is all done in the ultrasound from beginning to end. But this is my process here. Yours might take a little bit longer. That's fine. It might be a little bit shorter. But we place the catheters in the OR in an ASC. We're usually in there for about an hour. We move on to a PACU. And my nurses in the PACU, not my nurses in radiation oncology, really maintain the patient at that point. I go to radiology for a 2-sequence, about a 14-minute MRI, and then a 2-minute CT, and then they go back to the PACU. And then when we're done with our treatment planning, which is usually an hour later or so, depending on my schedule, we come back for the 20 to 30-minute treatments, remove the needles, and send the patient back to the PACU, Foley removal, and to get packaged up and go home. In my center, this is usually 4 hours, but it could be 6. My real-time involvement is usually 45 minutes in the OR, about 5 minutes in contouring, another 5 to 10 minutes in treatment planning discussion, And then as the AU, I'm with the patient for about 20 to 30 minutes during the delivery and removal of the catheters. How about you, Albert?
So the process is very similar. One of we're lucky here. We have a lot of resources. So we have our own procedure room, and then so we do our procedures. We have anesthesia come down and work with us, and then our nurses are able to recover the patient in our procedure suite or the holding area right next to us. So we can bypass the PACU, and then our scanner is right next door. Our treatment delivery is right next door. So I think we could get it down to about 2 hours on average.
And how about you, Matt?
Yeah, ours is about the same length of time. You know, we don't have the access to radiology, MRI, and CT, so our CT and PACU are flipped relative to what you got. But yeah, about 5 hours start to finish.
So now let's get into the procedure itself, and I want to move efficiently here, and I apologize, we're not as efficient as I wanted to be at this point, but this is essentially the procedure, and this is intended as a checklist, and I'm going to go through each of these points, but this is something I actually take to the OR with me, and I'm not going to focus on it this moment as I'm going through the next steps. There are items that you bring to the OR with you that are unique to CT-based MRI or CT-based HDR and CT MRI-based prostate HDR. One thing we do is we numb up the prostate, and I'll go through that technique. The other thing is a MR compatible. This is what I use. Albert goes freehand. There's CT compatible, but I use an MR compatible template as I get MRs on everybody as soon as I place my needles. I do bring gold markers in patients I do monotherapy with. When you do this procedure and you move the patient, you suture the template to the patient different than ultrasound technique. And I always use a B&O suppository at the end of it. So a pre-plan is not necessary, but it is a point of engagement with your physicist and urologist. So I tend to do it. Not everybody does that. It's not necessary, but it's a point of engagement because you're going to disappear between the legs and you want people to know what you're doing. And this is basically a setup for me where I have my checklist on the left here. I have my pre-plan with discussion points for my urologist, my physicist on the right, and I have my image right up above me and with the perineum displaced by this IO-band. And then you do a timeout. Joint Commission requires it. It's an immediate pause by the entire team to confirm the correct position, procedure, and site. It's absolutely mandatory. And if you don't know how to do it, it's just one of the easiest things to do is ask a charge nurse. But it seems like these little things we're not taught as radiation oncologists, but they are so easy to learn. Okay, and then I go to an image. And the point here is, put the prostate in the same place every time, and you'll be rewarded by having, success every time. And I generally go right to a mid-axial plane. I try to make a symmetric prostate, but more importantly, I try to keep the urethra in the D row so I always know it is. And then I go to a sagittal plane, and I want basically the posterior prostate to be parallel with my probe. I don't care if it's 7 degrees or 10 degrees, but I can usually find this within a couple of seconds of being positioning the patient in the OR. And then we go and we do the Marquine block. I use 0.25%. I use approximately 30 cc's, no epi, and we move on to that and gold marker placement. I want to make a point about gold marker placement. It is very helpful at this point to take a pause to measure where your gold markers are in reference to your base and to your apex, to your posterior part. You can even take pictures of this and do some measurements. We always do. If I don't have an MRI, I'm always doing that because I can translate that into my contours a little bit later. Here is a picture, whoops, I apologize. Here is a picture of Marquine. This is the Foley balloon, this is the bladder. Your base is here. And this is the triangular area we're looking at between the SV the base of the prostate, which is right here, obviously, but SV, base of the prostate, this is where the nerves come out of the centrally from the bladder alongside the prostate. And this is the key step to finding comfort in the guy for the next 6 hours or so. Albert, you do a similar technique?
Yeah, we do very similar. So we start numbing more, I guess, near the apex along the posterior lateral, like the neurovascular bundles. Every time, one thing when you inject, before you inject your marcaine or lidocaine, you want to aspirate backward. The last thing you want to do is inject a bolus of lidocaine or marcaine in the systemic circulation. So you want to aspirate backward. And then we inject along the posterior lateral aspects. Then we go all the way behind the seminal vesicles and also by the, like in that triangle by the bladder neck. So it gives the patient like the marcaine. We use a mixture of lidocaine and marcaine. The lidocaine allows for quick action. We use 2 to 8, I guess, 20% lidocaine, 80% marcaine. The marcaine will last you up to 4 hours, so it allows for long-lasting comfort for the patient. That's what we do. Yeah.
Yeah, you need about a 15-centimeter spinal needle too. You have to seek that out sometimes, and if you need a product, I can always supply it. Okay, then we go on to needle insertion, and I generally start axial mid-gland, and I will place, starting on the upper left, moving to the upper right, and so we're downward. I'll place my peripheral needles, generally 14 to 16, 12 to 18 is also standard, but 14 to 16, I place to the axial plane first before I worry about my depth. This is an opportunity to place the needles in the SVs as well, which we have needles for. A couple tips is you do the anterior peripheral needles first because your internal needles and lower needles will create shadowing. It's good to crowd the posterior row here to make sure there's no scalpeling of dose. And then you can really advance your most posterior row to get into the SV. And why don't we take a moment? What's your trick with the SVs, Albert?
So the SVs, I think when you place the needles in the SVs, you want to the dot is, you always want to, you have to take into consideration the rectum, but when you put in the catheters into the SVs, I think when you withdraw the probe, the seminal vesicles tend to move anteriorly, on a CT scan. So we tend to aim on at least half in the posterior half or half of the middle of the SVs, I guess, on the axial plane more so. So yeah. This allows us to give adequate dose to the seminal vesicles, but without, delivering excessive dose to the bladder.
Yeah, a key advantage of HDR is you can actually implant the SVs. So let's go to a chat question here to the group. And I realize people can't see these questions perhaps, but a question about anesthesia. And of course, we all have choices of different kinds of anesthesia. In addition to the loco, in what I've always done, I've avoided spinos. That's been studied. I use a minimal anesthesia control. We use very minimal propofol because these guys go out and then they come up and you want them up and alert fast with minimal side effects. So we find that we can control them very easily with minimal anesthesia control. How about you in your clinic, Albert?
Yeah, so we do very low dose propofol. It's very similar to a colonoscopy. I mean, there are patients that in the past that didn't want propofol and they wanted for one reason or another to be awake, during the whole procedure. So we use a mix of Versed and fentanyl in these patients. A lot of times if you do a really good block, once that block sets in, patients don't feel, too much discomfort. So yeah. We've done, so I think it's very important to get this good block in. But if you need to supplement, you could do Versed and fentanyl, I would do, that's moderate sedation. I would start with 1 of Versed and, 25, 50 of fentanyl, depending on, how large the patient is and such.
So, and there was also a question about getting guys comfortable with probe insertion.
Oh, I have a,
Go for it.
so I think for like, especially with space shortage is something that some patients struggle with. So what you can do is, if you have Lido jelly, you can start by first doing a digital rectal exam on the patient, and you can take that time to dilate the rectum somewhat. And then so you let that Lido jelly set in, then you can, after like a few minutes, you can introduce that probe very gently into the patient. It helps to relax them more.
Yeah, I do that. I'll push on the muscle next to the anus, and I'll say, this is what you have to relax. I'll say, let your butt fall through the table. I'll say, relax like you're gonna have a bowel movement. There's just getting comfortable with your manipulating down there. It's an awkward scenario that you can talk guys through. Okay. So we do have a question about prostate swelling over 4 to 6 hours. HDR is about where the needles are, so you can work with any kind of swelling. That's period. 4 to 6 hours is a long procedure. I don't have a problem with long procedures. My procedure is literally, 15 to 20 minutes, but I do this every day. From the time you image then plan, there's very little change. You have a higher energy with HDR. There's a number of things you can talk about that really aren't an issue. Our level 1 data doesn't show that, if there is swelling, we're not seeing it dosimetrically, stuff like that. I think that's about the swelling of the prostate, not the time of the procedure. But I don't really see that as an active issue. How about you, Albert?
I totally agree. I don't, at least, before and after the procedure, I don't see a huge difference in swelling in these
Yeah,
patients.
so
right.
and let me move on here to the implant. So on the very right here is like a mid-axial plane where I place my implants, but I start by placing my top 2 and I'm rolling in and out. This is the GU diaphragm. This is the penile bulb. And I very keenly watch the urethra, and I want to keep it in the D row at all time. But I always watch my first 4 needles in particular around they should be splitting the penile bulb, not transecting the urethra. We do traumatize the penile bulb, but you can avoid it. And that's a very key QA point for me to talk about with the physicist and the urologist at the time of placement. A key part of CT-based treatment is you're going to move the patient. So you have the patient's legs cranked up, which is here on the left. And then before you place the needles to base, and before you suture your template, you're going to drop the knees because you got the pubic arch out of the way. You don't need to worry about that at this point. And you drop the legs to basically the comfort level that they're going to experience during the day. That's a key part of the procedure to avoid migration of needles. And then we go on to advancing the needles to depth. And this is, again, a point of communication. I'm very vocal and assertive during all this time. I tell everybody what I'm doing. What you're looking at is a Foley balloon. You can see I'm at mid-gland, I'm going lateral. On the lower part here, I'm advancing needles into the SV. This is actually just a shadow right here. I'll show that again. But we go needle to needle and approximate it to base on the sagittal plane. By implanting axial and then going to depth sagittally, you're really ensuring that you don't have a lot of bladder neck trauma during the case. Here's another look at it. You can hear me talking. We're going needle by needle, making sure everybody's comfortable. Another point of this isn't LDR where we're searching for like a 0 plane or a 5 plane. I'm placing those needles, what I would say, uncomfortably deep. I'm very comfortable, even if I'm not going to use the depth of the needle, I'm pushing them beyond the prostate wherever I can. So further imaging, and then we'll talk a bit. Again, this is another guy where I'm placing needles inside the SV at many points so I can carry the dose not only to the SV, I don't always want to do that, but I can carry the dose to the base very easily. And then finally, this is what a cystoscopy looks like. I'm going to stop here and say, this is my needle in a guy's bladder. And so you don't have to do a cysto, but it does help sometimes. And this is me identifying that needle. It's usually the top two and pulling it out. In fact, anywhere where the urethra is and there's a needle, always start with the top two, even if it's at the bulbar urethra. It's generally where the urethra comes down and then goes into the apex. That's a point where you can contact the urethra. And then again, in the bladder, you can see your needle. And that's a look at that. Albert, Matt, do you have something to share? Maybe talk about how to get our needles to the base without there being an issue?
So just stepping back, I think when we're placing the needles, we always reassess on ultrasound, like how our coverage, we can kind of predict how our coverage is going to look. You can make adjustments accordingly to make sure that you have adequate coverage of your target. When you put the more medial catheters, right, around the urethra, you don't want to put them too close to the urethra or you can't use it. This is an important part. You want to have like it's space enough, I would say at least a centimeter of space away from the urethra, on those medial catheters, so that you can use those catheters and tune the dose accordingly. I think we don't necessarily use the sagittal view to adjust the depth. What we do is we adjust the depth on our cystoscopy. We advance the needles so that it tents the bladder. You can see the needles start to push against the bladder, but it doesn't penetrate through the bladder wall. It just touches the bladder, so that the bladder sits right on top of the prostate. That you have adequate coverage and you're not through, so you're covering the whole prostate base. So we found that it saves time instead of going one by one through on the ultrasound. And the ultrasound, we find sometimes when you have a ton of catheters in the prostate, it's hard to identify which catheter is which. So we use the cystoscopy as a way to fine adjust our depth.
Yeah, absolutely. Any other tips?
No.
So I'm taking us through just what I would do contouring on CT here. I can use pictures.
I can see your screen. I can see it.
Can you see me now?
Yes.
All right. Thank you. So I'm going to delete that real quickly and kind of go back to it. So I'm going to this is my CT. I actually have hidden behind here my MR that's fused in the same session. This was a case a few weeks ago that I actually sent on to Matt, but I'm going to go through this. Albert's going to give you tips on how to contour on CT, but we've already gone through that. You're circling your needles, of course, but you have your gold markers. Here's one. If you measured where that is from the apex and base, you measure from where that is from the posterior capsule. It really gives you a legs up on what to do. I'll describe why I have these. I have some CT markers in there right now and what they look like. But this is basically, my contours that I'll do over a few minutes. Probably start, I would have measured this off, but this is probably a reasonable thing. And then, voila, you're done. Of course, on CT, it's very difficult to see the rectum. And that's what I'll tell you why I integrate MR. But this would be like a common treatment volume for me, catching either urethra or the prostate. Usually there's a little beard of prostate right here at the apex. This is the mid gland, and then going in the SVs as deep as I want to go, depending on my needles. Now, if I look at the MR, there's see, I did okay. So there's a few advantages with MR. See how I did? MR, you can see the GU diaphragm. There's no cancer beyond the GU diaphragm, so it just makes you better there. The other thing you see is this external urethral sphincter. This is about a cm of muscular urethra that has no cancer associated with it, and it goes into the prostatic urethra. Right here, for instance, that is not it's associated with cancer. Apical cancer usually spills out in this direction, peripheral zone. That is not. And I'm usually very generous with my urethra in this region to protect the external urethral sphincter. It's a key way to avoid strictures. Remember, I'm treating on my CT in this guy, so I'm going to trust my contour of the urethra on the CT more than the MR because I fuse these together. But the other thing is I can see my spacor real easily. I can see my rectum real easily. And the MR, you know, a good, you know, an adequate fusion just gets you, approximates it because it's really about the bladder neck and it's about the apex. And that's what you gain. That's the chief things you gain when you go to MRI. You just get geographically better. So let me turn that over to you, Albert, and I'm going to show another image. So I'm basically ready to send this on to my dosimetrist and my physicist at this point. Can you hear me?
Yep, I hear you. So I think, you know, you hit it right on the nail, I guess. In terms of when we implant, going back to if you can visualize the implant, when we place the catheters, we place it all along, like right on the inside of the capsule of the prostate. So it helps us to delineate the prostate. We also kind of capture images from the ultrasound and also get a mental image or cognitive image to you know, help us to define the prostate. To define the prostate base and the apex, you can see how Peter contoured. When you start hitting the pelvic floor, you can see the GU diaphragm. It starts to, the prostate area becomes almost like an hourglass shape. You can also see the right here, you can see the hourglass shape. And then also below that, the urethra starts to move anteriorly. So you can see that you're going to be past if you're by the apex, which is the most difficult to delineate. You're going to be past the GU diaphragm as you go more, as the urethra goes anteriorly.
I'm going to turn this over for Matt to plan. I'm going to address the chat questions with Albert. I want to show you real quickly. This is a case that was a direct MR planned. These are MR markers that you can see. I'm not going to take the time to level this so you can see them better, but you can see I'm just going to follow this one right here that I have in the upper left of that. And you can see how I can follow that all the way in. And I can reproduce my needles directly using an MR marker without the use of a CT, which is really, it's another step of putting the technology together to minimize side effects, to maximize targeting. I do this in guys, especially with salvage, especially in an area where I'm looking at a region of interest to boost. Okay, Matt, I'm going to stop sharing here and give it to you. And I'm going to go to the chat line at the same time. Okay. So hopefully I can turn it over to you. And let me monitor these chats real quickly. I can probably easiest. Do you have issues with ultrasound images with spacor? I'll tell you, no. HDR, you don't have to have this fixed LDR, fixed position with ultrasound like you do often with, I need to find that chat room. With LDR, you can move around the needles. It does elevate the prostate a little bit. So instead of the 1.5 row being your bottom row, often it's the 2. Oftentimes with spacer, I don't use the entire 10 cc's if I'm going on to an HDR, even a little bit of separation. 4 to 5 millimeters with 5 cc's, 7 cc's is plenty. That's my own little thing. I'm not recommending it. It's just what I do. So that's one thing. Let me monitor this and summarize a few questions, and I'll turn it over to you, Matt.
Quick question. thing regarding the spacer. If you do spacer before the procedure, you want to sometimes when you do spacer, you introduce air into the area, and then it will obscure the ultrasound image. So you want to do spacer at least what spacer recommends 2 days before any a procedure, whether it's HDR or PPI. I think we at times do spacer, in combination with our brachytherapy procedure. And you want to do that at the end of the procedure, because once you put in all your catheters and then it's all set in the right position, then you inject your spacer. Then if the spacer introduces air, you don't have to worry, you won't ruin the remainder of your procedure because you can't see anything. So that's an important part. Yeah.
And just to address a few things, there's a lot of solutions for needles and stuff. I use the Flexa needle. I use a 5 French, even though my template will handle a 5 French or 6 French. The MR markers from C4 Imaging, FDA approved, etc. They work well with both the 5 French and the 6 French. The 6 French with the MR markers is probably a little more ideal because there's air around the MR marker, so you can see it a little bit better on CT. Air in the CT is good. Today, Matt's going to describe what afterloader and treatment planning software he's going to use right now. And then Albert uses FlexiGuide needles from Best, just FYI.
Okay, thanks, Pete. Albert, excellent overview of the implant contour. So I'll pick up here in the treatment planning system. So this is our treatment planning system at Emory St. Joseph's Hospital. We utilize on-center brachy. Keep in mind we have a microselectron afterloader. So if you have a Flexitron or another vendor, some of these things will differ. But I'm going to try to focus on principles that are true kind of across platforms. So this is the same case that Pete was just contouring. This is the CT. And at this point, the patient has gotten back down into the department. Before the CT was done, the metal obturators that were inserted into the needles to make them rigid and implantable have been removed. And we've put additional markers in here, radio-opaque CT markers. These are black cat markers by Electa. And you can see in a sagittal here, kind of the structure of them. They light up nice and bright. They have a long radio-opaque strut, I think it's nitinol, that goes down the body of the needle. And at the distal end, you have a centimeter air gap and then a final distal dwell position marker here. So these are not mandatory for planning. You could just digitize using the inner lumen of the empty catheter. But where these kind of shine is patients who have a metal hip or bilateral metal hips, and the artifact obscures your ability to see the catheters. With these black cat markers, it has enough contrast, you can still readily visualize the catheters and digitize and proceed with the case. So I'll start digitizing. We're going to do kind of 3 things here. Digitize the needles. We'll optimize the dose distribution and then analyze the resulting DBH. So I know we've got 16 needles. I'll populate all of those and then immediately go ahead and enter in the indexer lengths and offsets. So I know for these particular needles with this marker, the indexer length is 123.9 centimeters with no need for an offset. I know this because the manufacturer states it, but also as a physicist, I'll do an end-to-end test. So here's a film that I shot for these 240 millimeter needles with the black cat marker. Just take the needle down to a piece of film marked where that black cat marker distal dwell position is and irradiate. So, trust but verify. When you start digitizing, an important aspect of doing it accurately is to indicate which end you're starting at. For these prostate cases, I like to start down here near the template at the connector end. So I'll specify that in the TPS. That's an important aspect of getting it right. Now, this is the MR compatible template that Pete uses. We typically use the square CT compatible, but in either case, you know, I would have come back down into the department with a paper template where I've sketched out the pattern of the needles from the implant. And I can use this to identify which needle is which. We number ours top to bottom, left to right. There's really no wrong way to do it as long as you're consistent in your practice. I like to use this next catheter sequencing tool. And what that allows me to do is to jump from one catheter to the next on a single axial slice without any button clicks in between. This is as opposed to, say, going all the way down the implant on catheter 1 and then coming back to the start. I think there's a little better workflow. You don't have to digitize on every slice. You can skip through. The project current catheter tool is handy for helping you keep track of where the needles are as you get deeper into the implant, because they will start to drift from their initial position. As we get into the prostate, you'll start running into slices that have those gold markers on them if you use those, and you want to avoid digitizing there because it obscures your view of the rest of the needles. Towards the tail end, the base end of the prostate, I'm on number 1 now, and you can see that radiopaque marker drops out. We have a centimeter of air, and then there's that final distal dwell marker. So I'm going to put my final dwell position right there. So 4 really key aspects to accurate digitizing are the indexer length offset, the orientation, meaning connector versus tip end, and then where you put that distal dwell position digitized point. And all 4 of those things have to go together to be right. I like to view in sagittal that distal position that I've digitized and make sure it's right in the middle of that marker. Move on to number 2 here. And same thing, just scroll through sagittal and kind of do some QA, just make sure that we like the position of that. I'm not going to go through the next 14. It only takes about 8 to 10 minutes to really carefully digitize all these, but for the sake of time, I'm going to skip ahead to a saved case where I've digitized each one and talk a little bit about further QA of the catheter reconstruction. So when I'm done with each one, I'm going to scroll back through one last time and just double check that I've got the distal dwells digitized accurately. Double check again the indexer length and offset, and then load up a 3D view. I like to look head on. What I'm looking for here are any possibility that I might have crisscrossed needles as I was going deeper into the implant. I think that would be readily visible in this 3D view if I had. You can kind of get a side-on view and turn on some of the structures. And verify that your orientation is correct. Oncentra has a nice feature where it has this kind of visualization of the connector end in red. I want to make sure that's at the patient's feet. The tip end is in this gold, and that should be down at the bladder interface where it belongs. So that all looks good. So at that point, the case is digitized, and we can go on to optimizing the dose distribution. So Oncentra has an inverse planing solution called IPSA. We have some pre-configured solutions. And I will point out that in the handout that went along with this presentation, there is a sampling of some example optimization parameters in there. Okay, so that's done. It really only takes a couple of seconds. So now we can review our isodose distribution.
And there we go.
Yeah. IPSA tends to do a pretty good job right off the bat. So at this point, I would just scroll through from apex to base, analyzing the dose distribution. What I'm looking for here is a nice conformal plan where the prescription isodose hugs the edges of the contour. I'm looking for.
And Matt, when you're ready, can you bring up the DVH that I would be wanting to look at?
Yeah, sure can. You know, kind of hallmarks of a good implant that provide a good dose distribution, like Dr. Rossi was saying, those anterior two being up and in to avoid a cold spot anteriorly. The peripheral needles about 8 to 10 millimeters apart, really packing the needles into the posterior to avoid scalloping. So I know these numbers are a little bit small on the display, but we have a constraint table, like a pre-configured constraint table with a mixture of ABS, RTOG, and some in-house constraints.
Yeah, I mean, I think when you look at ABS energy, it's really the minimal. We always do a little bit more of ideal. We're looking to get a little bit better implant than that, frankly. You can see the V100 here at a quick pass is over 95%. We can push that up to 98%. The V150, V200 is what it is, but this would be common, this ratio of like 3 to 1. The D90 there over 100, but over 105 to 120, 115 is great. You know, if you RTOG is V75 less than 1 cc, you can see here at 0. I look at a V65 or even tighter constraints always. And there's a lot of experienced providers on here that, you know, the urethra is what it's all about, and it's controlling the urethra controls for long-term side effects that, you know, incontinence, stricture, issues along those lines. And this is already ideal, but I know in my hands, if I can keep the D10 about 115, less than 118, I will never see a stricture in that gentleman if I've respected the external urethral sphincter and the bladder neck. And I truly believe that. That's evidence-based. I can show you the data. But, you know, I learned from people like Gerard Morton told me that, and I integrated it from the very beginning 15 years ago, and it's led to great success with control of GU side effects and GI side effects. And we look at multiple endpoints. These, when we did the workshop, we got consensus from 10 providers on what they look at for their DVH endpoints, and we summarized them and just, you know, it was meant to give them to you, to spoon fed it to you. You don't have to make this stuff up. This is all evidence-based. We have long-term toxicity based on this data and these planning tools. And Albert, what do you look for at the urethra?
So the urethra, you know, the RTOG is V125 less than 1 cc, but we like to have a max dose of 0.1 cc less than 110%. And if the patient's had a prior TURP, you know, or if it's a salvage procedure, HIFU, we like to keep the max dose to the urethra less than 105%. I think, like you mentioned, the urethra is our dose limiting organ, especially, you know, with spacer nowadays, like there's almost no dose going to the rectum pretty much. And the spacer allows you to more flexibility. You know, some people, I think, there's pros and cons with spacer, but one of the things is it allows you more flexibility to pull the dose backward. Yeah, in this.
So point here, I don't have contrast in the bladder here because I get an MRI and I base my contours on that. But, you know, a little bit of diluted contrast would just make that glow. I delegate imaging to radiology. They do a heck of a job, and it's very efficient on me not to have my staff doing that. That's why I do that. I have a question for Matt, but let me ask, there is a question here. It says, is your D10% less than 100% rule for the urethra or the urethra plus 2, plus 0.2? And you know, and this plan here, it's CT contouring of the urethra. In my mind, I start by looking at urethra plus 0.2. I contour not the Foley, but what approximates what a true urethra does. And I start there, and if I can't meet that, then we work on it. But that's how I do it. And that has led to success in my practice for controlling for urethra toxicity, having high biochemical control. And I do the D10 less than 118, 115 more ideal, never over 118. I think you can achieve that. You're either going to place 2 or 4 internal needles. If you know where the urethra is, place those about 1 centimeter away from it. You'll have great coverage and never a problem with a hot spot. Albert, what do you think?
Yeah, I totally agree. Like you mentioned, we talked about earlier, the most important is spacing out those needles away from the urethra to keep the dose away from that.
And the urethra is getting 100% of the dose. We're not underdosing it, right? And now, Matt, how do you proceed if you have some needles that cross one another?
So and that happens. You really just want to go slowly through those regions and track each one. A lot of times you can tell, they'll maintain their current trajectory as they cross. So you can tell which one goes in which direction. But it definitely bears, some very careful digitizing anytime you have something like that.
Sometimes like our physicists will, if it happens, like they'll put in a guide, like a wire, in a small metallic wire, and you can see where it's crossing. If it sometimes they're really
sure. Like one with a marker and one without. Yeah.
We have a question that says, do you have a max dose limit to the target, which is the prostate? And then how high a dose of D90 or V100 do you allow? And Albert, if you followed that, will you take that?
Yeah, I mean, I always think of the prostate as a parallel organ. I don't really have a max dose. I think we want to ensure coverage. Our V100 should be greater than ideally 97%. If 95% is acceptable. Yeah, and now people like Gerard are doing focal boosts to lesions, to DILs, and it's been shown to be safe.
Yeah, I think by definition, maybe 120% is too high for the D90. Otherwise, I'm like Albert, and you'll find I use a lot of different treatment planning softwares, variant solutions, selective solutions. You'll see variation in the V150 and V200. One might be a little bit hotter than the other. That doesn't matter. We like heterogeneity. That's what we like. But we also need to control dose the urethra and rectum, especially at the apex where the urethra is. We need to cover the base. And MR does help with that organ at risk. So there's a question about what max dose do you keep the bladder dose under? And there's an admission that sometimes my bladder dose is high near the prostate base to cover the prostate. So that's my thing I worry about the least. And sometimes my dose is very high there too. And we have published guidelines on what to try to keep it at, but there is acceptable variation of 1 to 2 cc's, which is like 200 and 300% beyond what we recommend that is acceptable variable. What do you think?
Yeah.
I'll just point out that in the handout, we provided a sampling of dose volume constraints from some institutions in North America. So you can kind of see it varies in some places, and in others it's rather consistent. I think the bladder is one interesting one because a couple institutions don't claim to have a constraint bladder.
I never, so this is a thing, you have to be true to yourself, know your own program. I sit down with my team and we review our implants and we review how we could have done something better from one time to the next. Maybe it's a little depth in the needles that we didn't have one time that we're going to seek better the next time. And then you've got to know your outcome, follow your patients, follow them not only for the rare toxicities like a stricture or the need for a cystoscopy because of some sort of major LUTS or urinary issue, but I use an EPIC CP on all patients prospectively. I monitor their quality of life before and at every time I see them afterwards. So I know what I'm doing and I know if I have a problem, and I get the urologist together. It's a great form of communication. You show them 2 and 3 year data. It's like, this is how we're doing. What do you think? What have you heard? What have you seen? Because sometimes there's rumors of you torturing their patients and doing crazy stuff. But, you know, the reality is whenever I've gotten people together and say, you know, tell me about that or tell me about this, you know, the stories aren't there, and you have really a lot of satisfaction in patients and urologists. You're not going to please everybody, but that's my experience. But that's about, you know, practicing, reviewing your program, constantly reviewing your implants with your team, and looking at your goals and looking to see if you're happy with where you're at. There's a question about the handout from Dr. Erickson, and I know that was the intent. We have a handout for our workshop. This is something that we can re-push out if you don't push out again if you did not receive it. Very easy. Dr. Song asked, please describe what you do to counteract needles drifting caudally between imaging and dose delivery. It's an excellent question. There's a couple publications on it, pro and against. I mean, Matt and I think for about 80 patients, probably a little over 100 patients that we did a CT scan after implant, and just before we treated the patient, and we looked at, I mean, literally 15,000 needles for this event of migration. There is potential for migration. It doesn't happen uncommonly, but it's usually on the magnitude of 1 or 2 centimeters, and it doesn't affect your dosimetry. So we were happy, just to lend on what I said earlier, you got to look at your own program and what you're doing, and you have to see if you're happy and if your results are good. We were able to show internally that we are not seeing migration that has any clinical significance. What I do is
1 to 2 centimeters. They're asking 1 to 2 centimeters, or
no, 1 to 2 millimeters. Oh, I'm so sorry. Now, I think the greatest variation we had, Matt can tell you, was like 3 millimeters and like 1 or 2 needles. That's usually the anterior base ones. But how you correct for that is in the middle of the implant, I place the needles axial, and then I drop the legs before placing them to base and securing them. Key step number 1. Then I immobilize on a Schlesinger table, very careful with my team to transfer the table, and then they're immobilized with Velcro on their upper thighs and lower thighs, and you get very little movement. And then at the CT, if you're unhappy, you can always advance further. I do that very rarely, but I'm never afraid to go and advance a few needles if I need to get what I want. You know, you can use a technique. Albert, what do you do with the cystoscopy to make sure that you're at the base?
So on the cystoscopy, to make sure we're at the base, we tent the needles so that we see that the needles are pushing right up against the bladder. I think to ensure, for us, we use a freehand technique. We don't use a template. So we use this technique using dental putty. Actually, Joe Shu was the one that taught me from UCSF how to do this. But I think it's important. So in order to hold the dental putty will grab onto the catheters, and we have like some what we call friction collars to keep everything in. But to hold everything in, we actually throw in very deep countertraction sutures, so that, you know, all the I guess the adipose tissue in the perineum, you want to account for that movement, that drifting. So you want to get these needles very deep, so yeah, your template doesn't move back and forth too much. Yeah,
those are a lot of great points. And Dr. Song, I think it's a big issue that people have talked about. Ultrasound based planning eliminates it, but you got to kind of live within your system. At one time, about 3 years ago, I surveyed people in the US, and 70% of them had access to CT-based HDR, only 30% ultrasound. I think you can have a successful quality program. 0321 is all CT-based outcome, which was a phase 2 study with the Energy, obviously, with 10-year median follow-up, public data. I think you can have a very quality CT program, but you have to watch your needles and know what you're doing. And usually, you know, this is kind of one of these processes. If you're seeing needle migration, you might want to spend the day following your patients to see what's going on. Because I leave my patients after the OR and I don't see them again until they're about to get treated. But I spent my manager, myself, I've spent the time following them through that process, so I know everything that's happening. So it's a QA step that I've gone through. I know we planned in an hour. We're at our hour and 15 minutes. I really hope this was meaningful to everybody. It was recorded. It will be on our ABS YouTube. It's really an honor to be able to present this to you. I really have it. We have a huge mission of creating meaningful content through this year. I know we can't be together to do these workshops, but hopefully this is this will help someone that's struggling in practice, maybe give you a few tips and tricks along the way. I really appreciate Dr. Chang and Matt Giles for their support in bringing this to you. Also, Melissa Pomerine, I want to remind you that we have another webinar a week from now, February 4th at 4 p.m. And this is a physics-oriented, the medical physics nuts and bolts of MRI and GYN prostate by Dr. Zubira Kohan and Dr. Murtada. Really excited for that one. I want to remind you of the call for abstracts. The deadline has been extended to February 28th. We're really looking forward to all the great publications that are being generated in this pandemic and in this time away from group meetings. We are accepting applications for the 2021 class of fellows. Membership, we have the active campaign going on right now. There is a membership grace period. We really hope you renew your membership. We hope we're giving you value back. We hope to bring you a tremendous amount of CME and SAMs if you cannot be in live meetings this year through this sort of vehicle. And I'm just checking the chat real quickly. Any last thoughts from our panelists? Well, thank you, everyone. On behalf of ABS, we're going to sign off now. We appreciate it so much. We're always accessible to you. I really love direct MR-based HDR planning. That's kind of where I'm going with things. Also, AI-oriented contouring and planning so that we can just get from beginning to end as efficiently as possible for the patient. Also, making you as capable as you can be with your team in the OR, making that a process that you're confident in with that. So when you go into the OR, you know where it begins and ends. There's no obstacles that you can't overcome. I think that's a key part of being an HDR, LDR prostate brachytherapist, and that's what we want to help you with. So you can always reach us offline. Matt is really the best I've worked with, and he's been in every scenario. Albert's the best brachytherapist and has been in these scenarios, and I really don't hesitate to reach out to us. And thank you for your attendance today.
Thanks all.
There we go. Thanks, Albert. Thanks, Matt. Excellent. Thank you, Melissa.
Thanks, Pete. Appreciate it.
Yeah.
My pleasure to be here, really.
Thanks, everyone. You guys were great.
Opportunity.
Excellent.
And thanks, Pete.
Yeah, we're all signed out now. Yeah, good job.
Great. Yeah.